Hi, my name is Dr. Kara King. I am section head of our minimally invasive gynecologic surgery group, as well as program director of our fellowship. What is endometriosis? Endometriosis is when tissue similar to the lining of the uterus implants outside of the uterus, and it can really implant anywhere. The most common locations are going to be in the pelvis, so behind the uterus on what we call the uterosacral ligaments or the pelvic sidewalls. It also can implant within the ovaries, which are called endometriomas or cysts within the ovaries. It can implant on the bladder, on the bowel, but even in the upper abdomen on areas like the diaphragm or the appendix. Endometriosis has different stages of disease, so stage 1 through stage 4. So stage 1 disease is going to be more superficial lesions, and stage 4 disease is going to be deeper infiltrative lesions. What does endometriosis look like? So endometriosis can look like a lot of different things laparoscopically when you're actually in the body, which really adds to the complexity of the disease. So the most common appearance of endo is oftentimes these red-brown lesions, but it also can appear as red, as white, as fibrotic lesions, which can almost look like thicker plaques, as papillary lesions, which are clear, almost bubbles on different organs, or even just a lot of adhesions or fibrosis. So adhesions can be when all different organ structures are actually adhered together. So the bladder can be stuck to the uterus, the rectosigmoid colon can be adherent to the backside of the uterus or the cervix, and the ovaries can sometimes be stuck together and then stuck to the back of the uterus or the rectosigmoid colon. How is endometriosis diagnosed? First and foremost is going to be patient symptoms. That tips us off on diagnosing this disease. The main symptoms are going to be painful periods. Sometimes this does progress to actually having pain in between periods as well. And we also see patients with painful urinating, painful bowel movements, as well as painful intercourse. Second is going to be physical exam. So understanding what the pelvis feels like. Do we feel endometriosis nodules? Do we feel adhesive disease? Step 3 is going to be imaging, so ultrasound plus or minus MRI, and then we include surgical excision, and that typically is with laparoscopy, where we look at everything in the pelvis and upper abdomen, diagnose it, excise it, and look at it underneath the microscope for pathology. What happens during endometriosis surgery? Surgery really looks like typically a minimally invasive approach, so that can be with conventional laparoscopy or the assistance of a robot. When we go in, we look at everything. So we look at everything in the pelvis and the upper abdomen. Your uterus, your cervix, your fallopian tube, your ovaries, your pelvic sidewalls, everything behind your uterus, between your uterus and your rectosigmoid colon, everything in front of your uterus, between your bladder and your uterus, all of your bowel, your appendix, your liver, and especially your diaphragm as well. And so we use very specific cameras and specific patient positioning to make sure we don't miss any disease. One important aspect of endometriosis surgery is excising or removing the lesion entirely. What this allows us to do is, number 1, remove the entire lesion and know that we got to the very base of it. It also allows us to excise lesions over important structures like the ureter, the bladder, the bowel. And it also allows us to actually get tissue to look at underneath the microscope to confirm by pathology it is what we think it is. You may hear people talk about the word ablation, which is when you can actually just burn the lesion. In our practice, we promote full excision when possible for all those reasons that we just described. What is a prognosis after endometriosis surgery? It is considered a chronic disease, and so it unfortunately can return. Diagnosing it early and then having it fully excised are really great ways in helping minimize the disease and optimizing outcomes. Your physician may also discuss with you the option of hormonal suppression or some form of birth control to keep the disease at bay. Now, if your priority is pregnancy, then this should not be part of your treatment plan, because when you're on hormonal suppression, obviously you cannot achieve pregnancy. So every single patient, we have a very specific conversation, meet our patients where they are in regard to long-term optimization of pain as well as fertility.